This is chest pain related to a Stemi. My name is Jennifer Adams. This is for nursing 6917, due 2/17/25 with Miss Melody Wright, APRN MSN MP-C. Introduction to complaint. My patient is Michael Scott. He is a 55-year-old male presenting to the office for complaints of mid-sternal chest pressure. Patient reports the pain started last night but intensified 30 minutes ago when he was taking his daily walk. Patient reports an 8 out of 10 pain. Patient reports radiating left arm pain that does not radiate to his jaw. Patient reports that the pain is not relieved with rest. Patient does have shortness of breath but denies nausea and vomiting. Patient reports that he has been stressed at work, stating that his manager duties are demanding. His symptoms are the crushing mid-sternum chest pain that radiates to his left arm. He's short of breath. Pain is not relieved with rest. Some important questions that you need to ask this patient. When did the pain start? The pain started last night, but was only a 2 out of 10. Is the pain relieved with rest? No, I took a seat when the pain started to get worse, and it did not help the pain go away. Is the pain worse with exertion? Yes, I had to have someone pick me up at the park. Have you had this pain in the past? I did have chest pain in the past. However, it was GERD, and the pain was a lot worse today than it was in the past. Does the pain radiate to your neck, jaw, or arm? Yes, the pain is shooting down my left arm. Are you having difficulty breathing because of the pain? Yes, I feel short of breath. Medical history. Past medical history is hypertension. Surgical history is none. Family history. His dad is alive, has a history of hypertension, and an MI at age 58. His mom is alive with a history of hypertension. Social. He is a manager. He smokes half a pack a day for the past 20 years. He does drink alcohol on the weekends, only 2 to 3 drinks per week. He denies drug use, does state that he lives a sedentary lifestyle. Current medications include lisinopril 20 milligrams daily, allergies, seasonal allergies only. His vital signs, his temp is 97.8 oral, blood pressure is 180/99. His respiratory rate is 28, SpO2 is 98% on room air. His heart rate is 110 beats per minute. So from these vital signs, his blood pressure is elevated, he is tachypneic, and he is tachycardic. I forgot to include, he is overweight with a BMI of 32. Targeted physical exam. So obviously if this patient comes into the office, I'm going to do a more focused cardiac assessment and listen to his lungs and listen to his heart. However, for purposes of the class, I'm going to walk you through a head-to-toe assessment. General, he appears well-dressed and groomed, slightly overweight. Neurological, patient is alert and oriented ×3. Cranial nerves 2 through 12 are intact, denies any numbness or tingling. Head and neck, he is normocephalic, atraumatic, no lesions or masses on scalp. No lymphadenopathy, and trachea is midline. His eyes are pearly, conjunctiva is clear, sclera is white. Abdomen is soft, non-tender, no hematomegaly, hyperactive bowel sounds in all 4 quadrants, no palpable masses, no rebound tenderness, a negative McBurney's point, negative Murphy sign. He denies any nausea or vomiting. His extremities, no peripheral edema, peripheral pulses are +2 bilaterally. His skin, he is diaphoretic, clammy, no rashes or lesions. There is pallor noted. Pulmonary, cleared auscultation bilaterally, no crackles or wheezes. Patient is short of breath at rest. Cardiovascular, rate is tachycardic, rhythm is regular, accentuate S1 and normal S2, no JVD, no rubs or no gallops. He does have a new systolic murmur. Musculoskeletal, full range of motion in all 4 extremities, normal gait. Denies numbness, tingling, no joint swelling or tenderness. Does have left arm pain. Motor strength is 5 out of 5. And all 4 extremities, even though that left arm is painful. For this patient, my top 3 differential diagnosis. Number 1 is definitely a Stemi. I need to rule out acute coronary syndrome. The patient comes in, and any patient that comes in and complains of chest pain, that's the first thing that you think of. It also radiates to his left arm. He's diaphoretic, he has pallor, he has a new systolic murmur. He has pain that does not go away with rest. He also has a history of hypertension, family history of MI. His risk factors of him smoking and living a sedentary lifestyle can also lead to a Stemi. Also the fact that his dad had a Stemi at a fairly young age, 58, and my patient is 55. My second diagnosis is angina. This is usually triggered by exertion. which the patient was walking and the pain got worse. It can also present the same as a STEMI. You can also develop a new murmur. However, with angina, once the patient were to rest, the chest pain typically goes away. For pulmonary embolism, patient is short of breath and has a history of smoking, which puts him at an increased risk for a clot. He also lives a sedentary lifestyle, which puts him at even more of a risk for a clot. Patient presents with increased respiratory rate and heart rate and also has chest pain, which can be signs of PEs. Labs, diagnostic exams, and imaging, EKG. This is something that we would want to be done right when the patient typically walks in the door. Get the EKG, determine if there is ST elevation, if this patient needs to go, if we need to call the ambulance right away. If we have time, we're going to grab a troponin. This will be elevated in patients with a STEMI or cardiac disease. We're going to grab a CBC to determine if the patient has increased white blood cell count, determine if there's any infection or anemia since the patient is short of breath, CMP to look at the patient's electrolyte levels. Sometimes with chest pain, our electrolytes can get all out of whack. So we're going to look at their potassium, their sodium, their mag, and make sure that's all within normal limits. This will also let us evaluate anything renal or liver that might be going on. Since I included a PE and since the patient is short of breath, we need to grab a D-dimer. Since the patient could be having the PE, this lab will check to see if there are any clots. CKMB isoenzymes, this lab will show ischemic heart disease. Chest x-ray, because the patient is short of breath and having chest pain, this can tell us if the patient might have CHF, pneumonia, or an infusion. An echo, this would be ordered as long as the patient's EKG does not show a STEMI. This can diagnose abnormal valves, give us the patient's EF, and look for any ischemic heart disease. Coronary angiography is the gold standard for ruling out CAD. CT of the chest, since the patient is having chest pain, this will determine if the patient has an aortic dissection, pneumonia, or an effusion. So obviously, if the EKG does not show STEMI, and the patient is having chest pain, you're going to refer them to a cardiologist. The cardiologist, or you're still going to send them to the hospital. At the hospital or cardiologist, they're going to grab an EKG, recommend a chest x-ray, and send the patient for CT of the chest imaging. For treatment for a STEMI, the first thing you're going to do is call 911 to get the patient transported to the nearest hospital with a cath lab. Time is of the essence with this patient for survival. So making sure to grab that EKG first and calling transport to get the patient to the nearest hospital to get intervention. You're also going to give the patient 0.4 milligrams of sublingual nitroglycerin. Repeat the dose 2 more times up to 5 minutes apart until he doesn't have any chest pain. Have the patient chew a baby aspirin. Place the patient on 2 liters of oxygen for comfort. You can also give an analgesic for pain like morphine. Above, I included a picture of an EKG that shows ST elevation in all of the leads. This is what we call tombstone. This is something that would read STEMI across the EKG. And this is something that needs to be treated as soon as possible. Some non-pharmacological intervention. When the patient returns from the office after he's had a stent placed or after he's received PCI, he's going to follow up, and there needs to be teaching on quitting smoking, incorporating daily activity to his treatment plan, education on cardiac diet, healthy foods, support for a patient to continue cardiac rehab to improve cardiac function, improve risk factors, and survival. So lots of education for this patient on how to prevent any more damage to his cardiovascular system. And these are my references. I included our book and then 2 articles, one overview of the acute management with ST elevation, MI, and cardiac rehab indications. Thank you.